So welcome today to our academic conference. We hold this once a month to discuss matters of interest and application to the practice of healthcare. And today we have Dr. Emily Lund joining us. She was invited by Andrea Wright, who we all know and love in our libraries. And I'd like to turn the time over to her for the introduction of Dr. Lund. So Andrea, please go ahead.
Great. So thanks everybody for coming. It's good to see everybody. I had an opportunity to arrange some programming around LGBTQ themes as a member of the Diversity, Equity, Inclusion Committee. And so we have invited Dr. Emily Lund, who is an assistant professor of counselor education and rehabilitation counseling in the Department of Educational Studies and Psychology, Research Methodology, and Counseling at the University of Alabama. They hold a PhD in rehabilitation counseling from Utah State University, a master's degree in educational psychology from Texas A&M, a bachelor's degree in psychology and social work from the University of Montana. Dr. Lund's research focuses primarily on interpersonal violence, suicide, and self-injury in people with disabilities. But today they will be sharing strategies for addressing healthcare disparities in LGBTQ patients that they identified in their 2021 article in the Journal of Primary Care, Clinics, and Office Practice. So thank you so much for being willing to share this, Dr. Lund, and I will share that link to that article in the chat for everybody else.
Great. So thank you and welcome. Thank you for having me. As Andrea said, I'll be presenting on addressing LGBTQ health disparities in primary care and kind of what they are, why they exist, and how you as PCP, future PCP, the other primary care health provider can help to address them. As Andrea mentioned, the presentation was largely based on an article I published with a colleague that we bought in the VA, Privileges in Primary Care Clinic and Office Practice, which is actually a really nice journal that does special issues on really topic related to primary care. If you can't access the full text of the article and you want a copy, please feel free to email me. My email is at the end of the presentation. So first, I want to talk a bit about who are LGBTQ plus population, what we mean when we say that, and what are some other terminology you might hear and hear being used. So this is really a broad umbrella term referring to anyone who identified as either A, not heterosexual, and or not cisgender, which is to say they do not identify in the gender they is more assigned at birth. You sometimes hear the phrase gender and sex minority used as a synonym, or gender romantic and sex minority. Same concept, different terminology. You may sometimes hear the word queer to refer to gender and sex minorities. However, this is kind of a reclaimed slur, so it's considered kind of iffy when people outside the community use it. So it may not be something you would want to use with your patient, let you know they identify that way, and you yourself are known as a member of the community to them. We also see a considerable amount of both individual and generational variance in the use of the term queer. We see a lot of younger people, millennials and younger, using the term as a reclaimed self-identification. But if you had older LGBTQ patients, they may feel really uncomfortable with that term. I once heard older LGBTQ individuals say, I don't understand why you would call yourself queer, that what people yell at you before they try to kill you. So that is a term you'll hear within the community, but be aware it has kind of a difficult history, and it's one of those terms that should really only be viewed from within community context. We also know that identity and behavior are not necessarily all aligned. Not all patients who engage in non-heterosexual sexual behavior may identify as gay, lesbian, or bisexual/pansexual. And for that reason, we sometimes use terms in literature like men who have sex with men or women who have sex with women. You'll often hear, you may have heard a term like women who love women, WLW. Same type of thing. And likewise, you can't necessarily understand someone's identity or history from their present behavior or relationship status. For example, you may have a patient who you know is married to a man, but that patient may indeed be bisexual and have a significant sexual and romantic history with women that you aren't necessarily going to know about, that you're just basing it on what you see in the current relationship status. Likewise, the patient may appear transgender but may not actually identify as such. For example, I'm likely to be read as a cisgender female, but I actually identify non-binary. So we know as a broad group and at individual subgroup, LGBTQ plus individuals, a really long-standing group we know that are great rate for considerable health disparity. These include things like substance abuse, mental health disorders, suicide attempt and death by suicide, increased rate of cigarette smoking and problematic alcohol use, decreased access to utilization of preventive health care such as cancer screenings, and increased risk of some infected diseases such as HIV and other STIs. And particularly relevant to those in primary care, we know that access to sufficient routine and stable health care had really been kind of the historical major disparity within communities. Thankfully, we do see that disparity at kind of clothing for sexual minority individuals, but we really see the kind of gap remaining and in some cases even growing for individuals who are transgender or non-binary. This can be particularly true when it relates to these individuals seeking medical services to better align their gender identity and their sex. These would be things like hormone replacement, testosterone supplementation for transgender men, testosterone blockade and estrogen supplementation for transgender women, things of that nature. And as frontline physicians with opportunity to build long-standing relationships with patients, primary care providers really have great opportunity to intervene and address many of these health disparities and some of the underlying social determinants of health. Because as we'll talk about kind of throughout the presentation, these health disparities are really born of the long-standing ongoing discrimination and bias that people who are LGBTQ plus face. And as primary care physician and point of care, you all really have the opportunity to work with your patient, understand their situation, and then address these disparities. And an important note, the LGBT plus community here is not a monolith. We do see some disparity that tend to be pretty consistent across some groups. For example, we see most some group in the LGBT plus community at higher rate of suicide attempt and substance abuse. But we see other disparities may be more pronounced in specific subpopulations, and less pronounced at all. For example, we see higher rate of obesity among sexual minority women in compared to their heterosexual counterpart, but we don't see that same disparity among sexual minority men and heterosexual men. Likewise, we see that there are higher rates of HIV infection among gender sexual minority men, but we don't see any real sexual orientation rate differences in HIV rate comparing sexual minority and heterosexual cisgender women. However, we see that gender different kind of flipped in that transgender women had a much higher rate of HIV infection than do transgender men. So it's really important there not only to know your patient sexual orientation to reconcile with, but also to know their gender identity and how they would intersect in fact. And then we even see the differences at the level of behavioral versus identity. For example, one study found that elevated STI rate is particularly concentrated among men who identify as gay and bisexual and had sex with both men and women. But we don't see the same elevation among heterosexual identified men who had sex with men. That seemed to imply the behavior may be different between the groups. For example, perhaps heterosexually identified men are more likely to engage in preventive healthcare measures when they're engaging in sexual relationship than are men who engage in the same behavior but identify differently. So it's very important you understand your client's sexual orientation, their identity, their gender identity, and their sexual behavior. And you don't just stop at understanding one or having a partial understanding. And it's also important to remember that LGBTQ plus identities really intersect with other social determinant health and other advocacy and modulations, such as weight inequity and disability. And we know from the literature on multi-marginalized population in general that when you experience multi-marginality, you're experiencing the disparity and barrier related not only to the individual identity, but also to the intersection between their identity. For example, one area on which I've done some research myself is the intersection between LGBTQ plus identity and disability identity. And we know that disabled individuals tend to be assumed to be one of two things, either asexual or heterosexual. There's really no dialogue, no discussion within the general clinical discussion we have on sexuality and disability that really explicitly make room for non-heterosexual sexuality. So what we see is not only do people with disability in general lack access to good evidence information on sexuality, safe sex, in healthcare, but also if the person is both disabled and LGBTQ+, they really have no access to relevant information. And it can really increase some of the healthcare disparity. And unfortunately, this is sort of a glaring gap in our understanding of sexual minority healthcare disparities and gender minority healthcare disparities. And we, as a field, we done a lot of research looking at the intersection. We tend to look at them in very single access frameworks. We would say, okay, these are LGBTQ healthcare disparity. These are healthcare disparity related to African American. These are healthcare disparity related to people with disability. But we don't consider that people may have more than one marginal identity, and we don't really have a lot of good data on the healthcare disparity within the intersection of identity. And when we're speaking about LGBTQ+ health disparities, it's really important we think about them in a manner that non-pathologizing. So throughout history, healthcare and psychology had a really unfortunate history pathologizing sexual and gender minority identities and associated behaviors. One particular example is the fact that homosexuality, referring to same-sex sexual attraction or same-sex sexual behavior, was actually considered a diagnosable psychological disorder until 1973. And one of my colleagues who was attending medical school in the late 80s, early 90s, and it was a very prestigious Ivy institution, she still had attending faculty at the time who were offering conversion therapy for gay patients. So this, in it, like long ago, way back in history type of thing, this is something that relatively recent on history and something that really could have still had a significant influence on many of the patients you see in your practices. And we still see the same tendency to pathologize other sexual minority identities, such as asexual individuals, so people who experience no sexual attraction to anyone regardless of the individual sex or gender. They still face a lot of pathologization and invalidation by health providers and other people. For example, healthcare providers may immediately jump to, that might be some sort of problem, we might fix it, and they oftentimes conflate asexuality, which is a sexual orientation, with something like hypersexual drive disorder, which is a kind of sudden onset, distressing lack of or significant decrease in sexual drive and sexual desire. And it's really important that those two not be conflated and we not assume all asexual individuals are distressed or that they are necessarily a pathology. Actually, gender dysphoria, which is previously called gender identity disorder, is still a diagnosable psychiatric condition. So if you had people who are transgender, a lot of them may meet the criteria for having been diagnosed with what they currently call gender dysphoria and what would previously called gender identity disorder. However, the attitude toward should there still be a diagnosis in the transgender community are really more mixed and more nuanced, because the fact that there is a diagnosable condition, it has an ICD-10 code, that may make it easier for a lot of individuals who are transgender or non-binary to receive medical care, particularly in the medical care for transition, so hormone and surgery to better align their sex and gender identity. ideally, we would want people to be able to access that care without necessarily having a diagnosis, so that can be pathologizing. But unfortunately, with the way healthcare access works in the country, if we were to limit a diagnosis, it could unintentionally also limit off access to care. So it's kind of a difficult situation. And unfortunately, because we had that long history of assuming anything that's not heterosexual and cisgender is inherently pathological, we really created the kind of difficult feedback group where historically we took a lot of the health disparities in the population, especially those related to mental health, and used them as quote unquote evidence that the identity itself is pathological. And because the people who are gender sexual minorities a lot of times still feel a lot of stigma about their identity, about their behavior, and they still experience a lot of stigma from others. And then in turn, ironically, increases the psychological distress they're experiencing because they feel all the societal and internalized guilt and shame, homophobia, transphobia about identities. And what we found, unsurprisingly, looked at the research is really that the reason LGBTQ plus communities have such high health disparity is not because identity themselves are pathological, but because of the discrimination, the bias, the oppression that the community face, that increases the rate for the disparity, they increase the rate for negative socio-determinant health, and the so the pathway in a direct one from sexual and gender minority identity to health disparity, it's sexual and gender identity to oppression and discrimination to health disparity. For example, when we look at the higher rate of substance use difficulty in a lot of LGBTQ populations, what we find is this is actually a direct result of the discrimination and the marginalization the community has experienced. Because what happened is a lot of LGBTQ plus culture would fall into kind of the bar scene. And what happened in bar and club, people use substances. They drink alcohol, they may use other substances. And when you have a whole culture that it kind of built on that because that's the only place you can be openly gay or openly bisexual, openly transgender, you're going to have higher rate of substance abuse in that community. And similarly, we see that bias and discrimination against LGBTQ plus individuals really increases the rate for experiencing some of the other negative socio-determinant health, such as homelessness and interpersonal violence and harassment. And we know that the negative socio-determinant health just by themselves increase the rate of negative health security, such as mental health concern and chronic pain. They reduce access to regular and consistent health care. It's hard to have a consistent relationship with a PCP or a specialty clinic if you're homeless, right? If you're moving every few months or every few weeks. And they also create a level of chronic stress. And we know that chronic stress is really dangerous in terms of both negatively affecting mental health and negatively affecting physical health. So what happened is then you have a community that, because of all the advice and discrimination, is then exposed to wide other negative social determinant health. It exposed to chronic stress and basically had the perfect storm for not being able to access healthcare and experiencing higher rates of healthcare disparities. And the idea was really well conceptualized in what we call the minority stress model, which was developed by Elon Mayo and Fort Public in the early 2000s. And what Mayo said is, what are the mental health disparities we see in LGBTQ population, originally in gay men, but it been expanded to other LGBTQ populations? Is it due to anything inherent with sexual orientation, but rather due to the chronic stress of being exposed to violence, harassment, external discrimination, and B, having the constant pressure of having to conceal your identity, having to hide, having to conceal your romantic relationship, having to conceal your gender identity or your medical history. And what researchers have found is that model holds up. We see that the stressor, both the stressor and violence, harassment, discrimination, and the proximal stressor of concealment, internalized homophobia, internalized transphobia, really do explain a lot of the differences we see in mental health outcomes. So what does it mean for how people access or don't access care, the way in which they access it? So kind of like we know from the idea of proximal stressor, that concealment, that internalized homophobia, internalized transphobia, gender and sexual minority people kind of know they're a lot of times going into a hostile environment, an environment that may be hostile. And a lot of LGBTQ plus individuals for the reason will deliberately conceal their identity to their health providers. They'll lie about their sexual orientation, or they won't mention their sexual behavior, or they'll lie about their gender identity, or not tell providers, that they are vetted and appear to women now, but they will assign them both. And as we know in healthcare, it's really critical we get a good and accurate patient history. And the understandable pressure to conceal when sexual orientation and no gender identity really can get in the way of this. We know, for example, that sexual minority men may have higher rates of HIV. You may know you have a patient who identified as a gay or bisexual man. You may want to screen more regularly for high rate sexual behavioral and sexually transmitted infections. But if your patient then tell you that, you aren't going to make a decision with that risk profile in mind. We also know in the case of transgender patients that the health provider may not have a full knowledge of the client anatomy and physiology and any associated health risks. For example, you have a client who is a transgender male, but you don't know that they were assigned to both. You may not know or even think you are not screening for ovarian or cervical cancer. You may not know your client is taking or had taken in the past gender-forming hormone replacement therapy, so you won't be able to factor no consideration into your consideration of medication interactions, into your consideration of how that changes the risk profile for short-lived healing of conditions. And it really limits your ability to find good care. And it's important that patients aren't doing it to make it more difficult to seek good care. They're doing it because they have the really, unfortunately, well-grounded concern that if they tell their provider about their sexual orientation, sexual behavior, and their gender identity, they could be opening themselves up to discrimination, to receiving bad care, to even being kicked out of practice. So it very much seen as a matter of self-preservation among our individual and communities. And we often see that people who identify as gender and sexual minority will sometimes go out of their way to forgo care or to avoid care in that crisis to emergency. And a lot of it because patients report difficulty in finding providers they know are LGBTQ informative and confident around gender and sexual minority issues. So they just don't receive care because they say, I'd better not have care than go see someone who's going to discriminate against me. And we know when people don't have access to high quality, to thorough, to timely care, that we see a lot of risk for the exacerbation of chronic or acute illness or injury, the development of secondary health outcomes, and the increased likelihood of negative health outcomes. We know how important it is to diagnose and to intervene early and appropriately and to keep conditions well managed. But when someone doesn't have access to health care and doesn't feel comfortable accessing care, it can be really difficult to do those things. So what can you do as a primary care provider to address some of the barriers and to make it clear to patients that you're providing LGBTQ informative care? It's really important to understand that your patients who are LGBTQ plus may come in with a significant stressor, with a significant trauma history, with history of violence, discrimination, perhaps of being alienated from their families. Seeing that and understanding that these are social determinants of health and significant risk you may have to account for in your practice and in your decision-making algorithms. Also learn about health disparity profiling and social determinant of health for specific populations and multi-migrant populations. You have, for example, a client who's a lesbian transgender woman, learn about the health disparity specific to that population. Also use inclusion and positive LGBTQ-related personal brochures and other signage. They sound like it would be unnecessary, but what we know is a lot of LGBTQ plus patients will kind of read the room, physically look at the environment, and use that to determine is it a place where I'm safe to disclose my identity, or is it a place where I maybe need to pretend to be straight, pretend to be cisgender. Similarly, patients may take food from what kind of crowed and Julie the father agreeing. For example, if a patient sees the father wearing a rainbow or transgender colored flag, paper pin or name tag, at a written by a pronoun that kind of give the hint that, okay, this is a place that safely bestow, they know something about sexual orientation, about pronoun, about gender identity, and I can be more open with my. Similarly, including LGBTQ inclusion language or signage on websites and social media can be used to identify your clinic and the provider within it as being affirming. A lot of patients, when they're looking for providers, may specifically look for those type indications to see that someone I either want to bother make an appointment with. Also, consider how your intake people can set up. For example, if you have an open text space in which to identify one gender identity, it's more inclusive than just having two boxes you can check. You have to check one, male or female. Similarly, it may be helpful to have an intake form that allows patients to indicate their pronoun and full name. For a lot of your patients who are transgender or non-binary, they may have changed the name socially, but they may not have changed it legally. So on their insurance paperwork, on things that nature, it's still going to show up at their legal name, but giving them the opportunity to indicate, hey, you know, I have to go by something different, can again really signal that you're in a informing environment, in an informing environment. It can be honest with you about their gender identity and their history with regard to their gender and sexual bones, and then their current gender identity and the extent to which their sex matches that currently. And one thing prior to that is, you know, should I act about sexual orientation and identity? And the research kind of showed the answer overwhelmingly yes, as long as you do it in a respectful and informative manner. And the reason that because we can make assumptions about someone tonight about the sexual orientation based on things like their relationship status, their partnership status, their appearance, or other factors, and that assumption may be wrong, but it may be really uncomfortable and awkward for a patient to correct that. So respect and sensitivity toward patient previous experiences discrimination, exclusion, invalidation, harassment, and violence, while simultaneously avoiding stereotyping, overemphasizing the psychological and traumatic consequences of trauma. In other words, don't look at your client and say, oh, you had significant trauma history, therefore all your symptoms must be psychosomatic. We aren't going to do an actually solid workup. That happen a lot for patients who experience trauma and also patients who may have had a previous substance use disorder diagnosis or mental health diagnosis, that sometimes providers can assume if you have that in your chart, in your medical history, all your symptoms are psychosomatic. And because of that, we see that individuals with who had received mental health diagnosis tend to die earlier, in part because physicians will see that diagnosis, assume that the cause of all the symptoms, and not do a good thorough workup. So be aware that trauma, that discrimination can have the health effects, but also don't attribute everything to them. Also, it's really important that you maintain a formal environment by quickly noticing and correcting inappropriate or offensive comments by other staff, such as referring to a transgender patient by their previous name, what's sometimes known as their dead name, referring to a transgender client as actually their gender assigned both, or referring to an asexual or bisexual patient as confused, or like a quote unquote special snowflake, and just comment like that made by medical staff that can quickly build a culture and a clinic culture that, rather than being affirming, quickly showing themselves as non-affirming. And patients might overhear that, they might pick up on that, and that going to again impact how they disclose to you and that the care you can give them. And really work with the LGBTQ community to continually develop the culture of competency and identify and implement best practices. And it's really important, as we all want to work with people within the community to understand kind of current community needs, preferences, and trends. And also be aware of other LGBT conforming providers. If you need to refer a patient out to a specialist, know what providers are affirming and inclusive, so you can say, you know, I know that providers, they're really great with LGBT clients and LGBTQ issues. You're going to be safe there, you know, you can disclose. Similarly, if you're referring your client to community resources such as shelters or social services agency, again, be familiar with which one the LGBTQ forming, so you're not referring a client somewhere that potentially unsafe. Again, and finally, treat each patient as an individual. Avoid stereotyping. For example, don't assume all gay men engage in risky sexual behavior. If you had a client who identified as gay male, you may know that something in particular you want to know, but don't say, oh, you're gay, so therefore, you know, we're giving an HIV test and we're assuming it's positive. You could say, okay, so tell me about, you know, what type of sexual activity you're engaging in, you know, what type of protection do you use, and don't jump to potentially stereotyping them. Don't avoid both underemphasizing knowing and overemphasizing your identity. For example, don't assume that all health and mental health complaints are because they're a sexual minority or gender minority. But on the other hand, don't just dismiss the experience in the identity or how that may impact the risk profile. As we do all patients that take a thorough good history, because if you take a good history up front, even though it may take more time, we know you're saving time down the line, not time, by being able to do a good thorough workup and differential and make an accurate diagnosis and provide good accessible treatment. I'd like to open it up for questions and comments. You can see my email there. Feel free to email me. You want a copy of the article, a copy of the presentation, or you have any questions, you know. Always happy to talk about this stuff.
Dr. Lund, thank you so much for your presentation. I just had 2 points I really wanted to bring out: the intersectionality around race and even religion in dealing and intersecting with LGBTQ plus communities. I work in HIV stigma. And so your point about Black men, I mean, Black men are disproportionately affected by HIVs, and some of it has to do with the LGBTQ plus status, men having sex with men, 8 to 10 times higher than the other communities. This is a major issue, and some of it definitely the epicenter has moved to the South. And we believe that because religion is such a big part of the culture of the South, that's also an intersection that we have to think about. So your slide that talked about not pathologizing HIV, I thought about moralizing because I work with church communities, faith-based communities, but I also wanted to point it out for those of us who are providers as well, because we come with our own religion and biases, which also play an impact in really stigmatizing certain communities. So I just wanted to kind of lift that up. I like that word you used about patholog. What was it? Not pathologizing, right? Not pathologizing LGBTQ plus communities.
Thank you for bringing up the point about religion.
Yes.
I have several of my colleagues, they do work particularly on the experiences that LGBTQ plus individuals kind of within the religious community and the intersection between that. And that can be a really difficult thing for a lot of LGBTQ plus individuals, because a lot of times they feel rejected by the faith community, even though they may feel like their religion is really important to them, and that itself can create a lot of stress and tension. So thank you for bringing that up.
Yeah, the other point that I thought about was I know in a lot of black youth, a lot of Black LGBTQ plus youth, when they come out to their families, the families disown them. So there is a lot of homelessness of this particular subpopulation, which has a lot to do with not having access to care, et cetera. So just wanted to bring that out as well.
Yeah, that's a great point. And it's really unfortunate because we see a lot of time LGBTQ youth, particularly like you said, LGBTQ youth who are from marginalized racial ethnic groups such as Black queer youth. They're really in kind of the catch-22 in regard to their families and coming out, because coming out, like you said, can put you at risk for being disowned, for being kicked out, for being homeless, but also the stress of living in an environment where you know your identity and it respected can be a considerable stressor in itself. So it really is a catch-22 for a lot of individuals, particularly youth. Excellent point. Thank you for sharing those.
Looks like we have a question in the chat from Greg Bell. Do you find that when dealing with LGBTQ plus persons, providers and others feel more free to ask invasive questions that would not be asked of a straight person?
That's a great question. In my experience, it can really vary. You can get kind of two extremes. You can get people who ask really basic questions. I know a lot of my trans colleagues, they say like, everyone just feels free to ask questions like gender, they're not providing care, and that, you know, really inappropriate and really invalidating. On the other hand, you sometimes had providers who are really uncomfortable with sexual orientation and identity, so they're just like avoiding the talk entirely. Like if they're working a female patient who said, "Oh, I'm a lesbian," and they won't ask any further question about sexual history, even though things like sexual health behaviors are still important in the population. They feel less comfortable, so they feel they won't act and they won't get that important information. So it can, in my experience, really vary kind of between the two extremes.
I think one thing that really stood out to me was the suggestions that healthcare providers, offer some, make their intake forms more welcoming and make their language more welcoming. And that seems like really small stuff, but as a person who participates in queer communities in our area, every Facebook group, every email chain, every group of people when people come together and somebody new moves to town, or just you'll constantly see, I'm looking for LGBTQ friendly doctor. I'm looking for a medical, I'm looking for, every time somebody new moves to town or some doctor retires, there's a new discussion and it's brought to the forefront every time, because that is one place where people need to feel like they can trust the person they're partnering with on their healthcare. And so few people feel that. And so it ends up being a real, social network in terms of, oh, I have a doctor that you can trust here, let me get you their phone number. And everybody goes to the same one in the community because nobody else feels safe or feels comfortable. And that's such a big part of the health disparities, is just barriers to care, not feeling safe, not feeling like you have somebody you can trust to go to. That's a shame. It would be better if there are more physicians and healthcare centers here where people could say, oh, well, there's Dr. So-and-so and Dr. So-and-so, and I really like having him. But these chains are all the same. They're all really brief. They're all really short. It's a shame. It feels really limiting to people when they move here and they don't feel like there's anywhere to turn for healthcare.
Definitely too. And I think there may be more providers out there who are, welcoming and informative, but they don't do those things that signal to people within the community, hey, that person is safe. So the person never tell them, because a lot of LGBTQ plus people really understandably so, literally in a healthcare setting where they're in that power differential, are going to be on the side of concealment and not disclosing. In fact, they see those things like, okay, everyone had written the pronouns. Okay, there's a space on the form for, if your gender identity different from your sex of the same both, and they may, without the type of signal that say, hey, the person is safe, they may never disclose, even though their title may in actuality be a phone.
Right. So you're closing them off from the opportunity of disclosing to you by not either asking or displaying some kind of, prompt.
Mm-hmm. Yeah.
Anything else? We're running towards the end of time. We've got your email and we appreciate so much sharing with us.
No problem. Thank you so much for having me. Super excited to talk on that topic.
Absolutely. Anything else from you, Nathan? Great.
No, I think we're good. Thanks everybody for coming. Thank you, Dr. Lund, for your informative presentation. And we hope you all have a great day.
Thank you.